Hello and welcome to Chapter 7, Understanding and Managing Pain. What is pain? When I say the word pain, for each of you, something comes to mind, right? We've all experienced pain before. We know what that feels like. Even though pain is an almost universal experience, however, it can be really hard to define. And this is due to the subjective experience of pain. How painful something is and how pain actually feels is going to vary by person, right? It's universal, but it's also really unique. So for that reason, we have a hard time defining it. The International Association for the Study of Pain, however, presents the definition you see here. So they say that pain is an unpleasant sensory and emotional experience accompanied by actual or potential tissue damage. So this definition is saying that it's that pain that we feel, right, that unpleasant sensation, and this is often going to be accompanied by some actual damage in the body, although not always. This definition tends to be pretty agreed upon, right? Most entities that study pain think this is a pretty good definition, even though we do have a hard time defining it. Pain can be broken down into 3 stages: chronic, pre-chronic, and acute. Acute pain is the type of pain that you experience when you injure yourself or you touch something hot or you cut something, right? This is going to be that pain that's short in duration, and it's typically adaptive. So if you put your hand on a hot stove, this serves the purpose of having you remove your hand so you don't burn yourself, right? If you injure yourself, pain is your body's way of telling you you hurt yourself, and it's how we don't use, right? If you sprain your ankle, you don't use your ankle because it's sprained. Your body's letting you know that something bad's happening so you can avoid it. In contrast, chronic pain is pain that endures over months or even years. So this is pain that's associated with things like rheumatoid arthritis or all these chronic conditions. If you have an injury that doesn't heal, say a bad ankle or one of those long duration injuries, this is chronic pain. Chronic pain often persists in the absence of tissue damage. So a lot of times if you do scans, imaging to see these areas of chronic pain, it can be difficult to actually identify where this pain is coming from. Our chronic pain is going to be not adaptive, right? My acute pain, if I sprain my ankle, it tells me stop using your ankle so you don't damage it further. This chronic pain, right, when we can't really exactly tell what's going on, but the pain's still there and it's lasting over time, this is not adaptive, right? It can be debilitating. It can get in the way of people living their lives, doing the things that they need to do. A third category is pre-chronic pain, and this is going to be the stage between the acute and chronic pain. So continuing on with our ankle example, if you sprain your ankle, that first pain is acute, right? I've got my acute pain. That stage between where you're healing but the pain doesn't go away, this is that area where that person their body's still not sure, right? We can't identify whether this is going to become a chronic pain or whether it's acute and it's going to heal and the person gets better. There can be other categories of pain, right? Such as chronic recurrent pain, if it doesn't hurt all the time, but it is chronic. But these are going to be 3 stages that we can have our major categories of pain. Next, we're going to talk about how we perceive pain, or the physiological processes that happens while we experience pain. The somatosensory system is the system that conveys sensory information from the body to the brain, right? We understand our pain, we assess it in our brain. And this pain is going to come from all our cells in our body. This message that we're in pain gets sent up to the brain. The somatosensory system consists of several senses. So not just pain, but this is going to include things like touch, pressure, cold, warmth, tickling, right? If someone tickles your arm, it's the somatosensory system that is sending this information to your brain. And pain is going to be a big part of what this system helps us perceive. Nociception is the process of perceiving pain. All of the organs in our body, which includes our skin and our internal organs, everything that's capable of responding to pain, these are nociceptors, right? So my skin, if you pinch it or you scratch it, this is a nociceptor and it can send the pain information through my body. The two types of fibers that are going to be important in pain perception are our A fibers and our C fibers. A fibers send our messages from our nociceptors, right, our cells, up to the brain very, very quickly. And C fibers take more time to fire and to send these messages to the brain. So the fast pain that happens when you first hurt yourself, right, that sharp pain if you cut yourself or you burned yourself, that's going to be sent through the A fibers. And kind of a more aching pain, right, that dull sensation, dull type of pain, is going to be sent through the C fibers. These messages are sent when we send them from our cells or nociceptors up through the brain. The path that they follow is the spinal cord, right? This is all our pain signals come up through the center of the body and get sent to the brain. The first part of the brain where this information is going to go in the thalamus, right? This receives the information and then it sends it to other parts of the brain, including the somatosensory cortex. You can see a picture of the somatosensory cortex right here on the slide. This cortex is set up in the brain so that different areas correspond to different areas in the body. So if I'm sensing something in my face, we can see over here, kind of to the left of this picture, this is where we're going to process the information that's coming from the face, and then up more, we have our hand and then our leg. You'll notice that the areas here, the area for an organ that's allocated on the brain might not actually match the size of the organ. So, for example, even though our back is a very large area with lots of skin, there's less area of the brain that corresponds to the back than to the hand, right? It's a lot smaller, but when we experience pain in our hand, we've got this larger section of the brain that's going to process that pain. There's also something called referred pain. So even though we have specific areas of the brain that correspond to areas of the body, sometimes we're not actually able to locate our pain that well. So referred pain is going to be when damage is in one area, but we're actually experiencing it, we're classifying it as pain in another area. So for example, when someone's having a heart attack, so the actual damage is in their heart, that's where the physical process is going on, they might experience pain in their arm instead. This is a fairly common thing. Lastly, I want to talk a bit about neurotransmitters. Remember, we talked about neurotransmitters earlier. These are the chemicals that are synthesized and stored in our neurons. This is how neurons talk to each other. They send information using these neurotransmitters, these chemicals. We have neurotransmitters that respond to pain. So the way this discovered was there was a graduate student who got in an accident, right, was in the hospital recovering from this accident in a lot of pain and on morphine, and wondered, what is morphine, right? Why does this medication help me experience less pain? So looked into this, did some research, and thought there must be receptors in the brain, right, that are ready to accept this morphine, right? Why are these receptors here? Turns out that endorphins are the neurotransmitter that naturally occurs in the body that go to these receptors. So endorphin is going to be the neurotransmitter that responds to pain. So if you injure yourself, your body is going to produce this endorphin neurotransmitter. And this serves the purpose of kind of dulling the pain and getting you through something. So if we think of an evolutionary perspective, if I'm running away from a tiger or a bear and I sprain my ankle, those endorphins kick in and get you through the process, right? Let's power through this pain and then deal with the injury later. If you've ever experienced an injury playing sports or being active, right? Maybe you're running a race or you're playing in a game and then it doesn't hurt until later. This is your endorphins kicking in, right? They power you through to the rest of the game, and then your body, when the endorphins come down, you deal with the pain later. Now we're going to talk about different theories of pain. There have been two major theories of pain proposed. First is the specificity theory, and the second is the gate control theory. Specificity theory states that there are specific pain fibers and pain pathways that exist in the body. So I have specific receptors that are going to respond to pain. In this theory, the damage that happens in the body is going to be directly proportional to the level of pain. So the more damaged my tissue is going to be, the higher the pain. It's going to be a 1-to-1 thing. Research in this theory has looked to find specific receptors that correspond to different types of pain, right? So do I have receptors for my burning pain or for itching? Things like that. Those who have investigated this theory have not been able to find evidence of it, right? We can't identify specific receptors for burning pain or for itching or for warmth. The other theory that's proposed is the gate control theory. This theory states that there's going to be a gate in the spinal cord that will open and close and affect the amount of pain that gets in and the way we experience pain. This theory points out that our nervous system is always sending messages through our body, right? It's constantly sending all these impulses and signals from one place to another. And it's saying that there's going to be a physical thing in the spinal cord that can turn off or turn on whether or not this pain is going to flow through and make it through the brain. There is a specific location that's been proposed that might actually be this gate. In the dorsal horns of the spinal cord, one of the layers of laminae that's called the substantia gelatinosa is a thick layer in the spinal cord that has been proposed that actually serves as this gate. Remember we talked about the A fibers and the C fibers that send pain throughout the body? There are fibers in this location, and it's been proposed that these fibers that are sending our pain signals help to turn on and off this gate, right? Is our gate going to open and flow these signals freely to the brain, or is it going to close and decrease the level of pain? An addition to this theory has been the idea of a central control trigger, or an area in the brain that influences whether or not this gate is going to open, right? Kind of sends messages to this gate and lets it know whether the pain or whether the gate should open and send the pain or if it should close. This accounts for the idea that our psychological states can affect our pain as well, right? Things like anxiety or depression can cause this central control trigger to send this information to the gate, opening it, and sending higher levels of pain through the brain. While this theory is not universally accepted, right, there's still a lot of controversy around it. It is the most influential theory of pain and the one that's got a better basis in our physiology and fits our actual findings of pain, the research evidence, better than the specificity theory. So now we're going to talk a little bit about measuring pain. As we've discussed earlier, pain is going to be really subjective. It's hard to define. If it's hard to define, it's also going to be hard to measure, right? It's not very easy to measure someone else's pain. There have been a few tools that have been proposed to do this, though. First, we have rating scales, right? So this is when you go to the doctor, if you have an injury, and they say rate your pain from 1 to 10, or 1 to 100, right? This is asking for you to rate your own pain. How high on this scale is your pain? Of course, we know that this is going to be subjective, right? Is one person's 7 might be another person's 4. They've also kind of done this with things like faces, right? Where there's 8 or 10 drawings of faces and in varying degrees of pain, so you can point to the face that best matches your level of pain. This is going to be more effective if we're trying to measure pain with children or something like that than asking them to quantify with a number. We can also use pain questionnaires. The most widely used pain questionnaire is the McGill Pain Questionnaire. So this is going to be an inventory that provides a subjective report of pain. So we're asking someone to self-report, but instead of just asking them to give a number 1 to 10, we're asking them to respond to a number of questions. So this will address things like the sensory qualities of pain and the evaluative qualities. So people can say whether their pain is nagging, nauseating, agonizing, dreadful, or torturing, right? I give you these 5 words and I ask you to pick which one. So we're asking people a little bit more detail. We're getting a little bit more into describing the pain instead of just rating it 1 to 10. Practitioners have also used standardized psychological tests. So these are going to be psychological tests that are used in things like clinical diagnosis, right? Personality assessments that we can use specifically to measure pain. So even though these don't just measure pain, they do have some validity with pain patients, right? They can give us some insight. Specifically, the MMPI, which is a widely used psychological test, does give some insight into the experience of pain. It can kind of separate and classify pain patients. We can also use behavioral assessments. So this is looking at an individual's behavior as a way to get information about their pain. So when people groan or grimace or limp, right? How many days they miss work, how much time they spend in bed, look at the actual behavior, their facial expressions. It's been shown that healthcare professionals tend to underestimate patients' pain. So in order to do this, healthcare professionals need to be trained on how to look at the behaviors, right? How can we look at the way an individual's acting, watch their behavior, and use this to gain insight into their pain. Sometimes practitioners have asked other people to rate the pain, right? So maybe asking a spouse of someone in chronic pain to keep track of how many times they engage in pain-related behaviors, such as limping. Lastly, there's physiological measures. So this is when we're going to use some type of physiological way to quantify the pain. So if we use an EMG, right, this is going to be something where we can measure the level of muscle tension, right? We can hook someone up to this machine and we can measure how tight their muscles is. We can do things like a skin response, right, where you put receptors on their skin and measure the level of sweating. How much pain are they in? Let's take this actual physical measure. Unfortunately, reports have showed little consistency between self-report and EMG. As we know, pain is a very subjective experience. We can't always understand why someone's experiencing pain, right? The level of pain is not necessarily going to correspond to the actual physical damage in the body. So using physiological measures presents some difficulty. They don't give us the wide understanding, this comprehensive understanding of pain as we would necessarily like them to.